With my presentation, I just want to let you know a little bit about my personal story. I'm really an open book when it comes to this. My first touch point in the medical system where I was gaslit and dismissed was when I was 28 years old and I felt a lump in my breast. I was a second-year OBGYN resident, and my mom had just been diagnosed with stage 4 ovarian cancer. I was working all of the time, and all of the female OBGYN, my senior residents and attendings, some of them felt my little breast lump, and I told them my symptoms. They're like, you're too young for breast cancer. Just watch it with a couple cycles, Oh, it's probably nothing, Corinne. Just take another call, 24-hour calls, right? Like it was, ridiculous. And so I dismissed myself, and it wasn't until the day of my mom's funeral, because she died a few months later, that I was like, oh, damn, I should probably get this checked out. And I wasn't even nervous. And looking back, I'm like, am I crazy? My mom was only 54 when she had ovarian cancer. So, I should have really had a red flag. But, 23 years ago, if you think we weren't talking about, we really weren't talking about this stuff, right? So, long story, which could be its own presentation, but in 2001, right before the holidays, I was diagnosed with stage 2A ERPR positive, HER2 negative breast cancer. And in the middle of prenatal clinic, the stupid radiology resident paged me, and I picked up the phone, no cell phones, and said, oh, Corinne, it's invasive breast cancer. And I took the pager and I threw it across the room. I was hysterical crying. There was a pregnant woman who didn't speak any English in my room. And the very first thing that I thought was, I'm never going to be a mom. That's the first thing I thought, right? Not that I was going to die, but I was like, they're never going to, they're never going to allow me to get pregnant. So that began my journey of really having to fight for options and my rights, right? So I quickly learned that I was going to have a bilateral mastectomy. I was going to have 6 months of chemotherapy, and then adjuvant endocrine therapy for 10 years. And, I was fully unprepared for the side effects of premature menopause. And I wound up going through menopause not once, not twice, but 3 times. So the first time was temporarily from chemotherapy. It shuts down my ovaries, but I was young enough, those ovaries perked back up. Periods returned a little bit. So then second time was they were like, well, let's give you some Lupron. Let's shut those ovaries down. Lupron went to tamoxifen. So then I went through that kind of iatrogenic chemical menopause, which is real tough. And then because luckily I had a really great oncologist who knew the data back then, 23 years ago, said, the data shows us that pregnancy with high levels of estrogen don't increase your risks of your breast cancer recurring or you dying. So, Corinne, it's okay. You can get pregnant. And luckily, my ovarian function was still there. And I was able to get pregnant. So went off my tamoxifen, got pregnant, felt great. Menopause symptoms obviously all went away. And then a few months after delivering, I was like, okay, I'm going to go back, on my tamoxifen. This time I didn't do Lupron. I was like, I'm not doing that again, just did the tamoxifen. And then a few years later, even though they told me I was BRCA2 negative, I made the decision. I said, we've got one baby. We're going to adopt our second child. We went to Guatemala, adopted my little girl from Guatemala. She's 17 years old now. And I said, you know what? I'm getting these ovaries out because my mom died at 54. I had breast cancer at 28. My genes are screwed up, I know. So something's not right. I just want these ovaries out. And then I'll just take tamoxifen with, and I thought, big deal, like whatever, I can handle this because I wasn't trained in menopause. I had no idea what was going to hit me. And so then I had surgical menopause and just joined a new practice, and it hit me like a brick wall. It was the worst than the other 2 previous menopause. And that's when I knew I had to self-educate. I got involved with the North American Menopause Society, now called the Menopause Society, and just had to do a lot of education and started to slowly tailor my practice in that way. So that's how I got to where I am now. So unless you had been living under a rock, you must have seen this article, Women Have Been Misled About Menopause. It ignited the most important conversation kind of from a society standpoint publicly about menopause, that there's this FDA-approved treatment that's been around for decades. We've got tons of evidence on it, but women aren't taking it. So women were misled, but so were doctors, frankly, right? And I think before I go on, I'm going to ask us to pause, and I'm going to ask you, oh, one more slide and then we're going to do that. So basically we were all misled as doctors and patients, and it created something called the menopause management vacuum, or this menopause care vacuum. These are two leaders from the Menopause Society, and they wrote this, sorry, I didn't put my slide. So the menopause management vacuum. These two leaders, Stephanie Fabian and Cassandra Schufelt, they wrote that, only 7% of OBGYN, internal medicine, family practice residents felt prepared to provide menopause care, right? It leads people to seek out not very reputable, providers, offering them pellets and other junk, right? But this study went further and said only 34% who even thought a little bit knowledgeable about, menopause and hormone therapies, only 34% would even offer it to symptomatic, newly menopausal women without contraindications. And only 37% said that they would offer it up until the age of surgical menopause for premature menopausal women. So these are terrible numbers, right? And so before we go, really any further, this is what I was talking about.
2002,
I want you to
the
listen to
National
this.
Institute of
Film
Health
it.
called a full-blown press conference at the National Press Club in Washington, D.C. to make an announcement about the WHI study.
Good morning. First, women should not start or continue this therapy to prevent heart disease. The findings show it doesn't work. In fact, the therapy increases the risk for heart attack or stroke. Additionally, it increases the risk for breast cancer and for blood clots.
And then, to make sure the word got out, sent experts and officials to hit the morning and evening news circuit. Their message was completely unexpected and was shocking.
Now, when it comes to hormone replacement therapy, if you're taking it, get off it?
Yeah, you have to talk to your doctor. Get off cold turkey, taper. But if you have already gone through menopause and you think you're going to stay on these things till you drop dead, you may be swapping one problem for another. There is a cause and effect. There is proof that breast cancer rates go up. It doesn't make sense to stay on hormones.
So there's no question in your mind that this correlation is accurate?
There's no question in my mind. None.
What about there are other natural remedies, these bioidenticals on the market that a lot of women are saying, well, I'm not going to go on the hormone replacement therapy. I'll get this natural product instead.
This is like saying, I don't want to eat too much ice cream, but you go ahead and have your chocolate and I'll have vanilla. Hormones are hormones, no matter what we call them. So whether you buy them from a traditional pharmaceutical company or you get them made up in another pharmacy, hormones after menopause still give you artificially raised levels of hormones they're not supposed to simulate when you were 22. They don't make your bones stronger. They don't make your heart better. They don't make you smarter. They don't make your skin better, but they do cause disease. So I think this is a time to say, hey, look, menopause is not an illness. You don't have to treat it. You don't have to cure it. It's a rite of passage in one's life. If you need a short stint to help get through hot flashes, talk to your doctor about it. But do not think these little pills should be popped forever and ever and ever. It doesn't make sense. It's not safe. There is an absolute link to breast cancer.
In other words, it can kill you.
Absolutely. I took my mother off of them years ago. I wouldn't go near them, and you shouldn't either.
Dr. Nancy Steinman, thank you.
You're welcome, Mary.
And
number
then
of
from the
women
illustrious
diagnosed with the disease
Matt
dropped
Lauer, who we
dramatically
all love, right?
in the year after millions were warned to stop taking hormone pills. One doctor says the news is better than a cure.
Almost overnight, some 15 million women stopped taking the hormones. Many people thought it was an overreaction, but the latest study shows otherwise. In the year after all those women stopped taking hormones, the incidence of breast cancer, which had been steadily rising, suddenly dropped by an unprecedented 7%.
Okay, so this is what we're dealing with here, people, okay? So I don't remember any of this because I looked back recently. All the OBGYNs are like, I remember when the WHA came out. I'm like, I don't remember. I realized I was in the middle of chemo. So like the last thing I could, so it was so amazing to go back and listen to this. This is the trauma that was inflicted. This is just 2 clips. This went out on every news channel and it was nonstop. It was the cover of the New York Times. It went on and on and on. And so any doctors who were being trained then were like, oh my God, we can't do this. And the generation of doctors teaching residents now, they came up during this time, right? And important to note, the WHI primary investigators have walked back all of their claims, nearly all of them. They hold on to a couple. And their own data shows that it decreases the risk of cardiac events, all-cause mortality, and estrogen alone decreased by 30% the risk of breast cancer. But we're going to talk about that with this next slide. But I'm glad you guys saw that. I'm going to send you a link to see the entire presentation that has more of those clips. So this is what they were talking about. This was what Matt Lauer, the lover of women, was talking about, okay? So look at the black arrow, guys. That's the WHI year, okay? So then the red arrow is that 7% decreased risk. But they didn't read the footnote that the CDC, this is data from the CDC. The footnote from the CDC was you can't compare the numbers from 2002 to 2003 because we changed the method of calculating it, so there's not a direct comparison. So that drop, 7%, was meaningless. It meant nothing, but they ran with that headline. But then, okay, so that was a stupid, method that they didn't report on. But those headlines are big news. 7% drop in 1 year. It's not even biologically plausible. That's not how cancer works, right? But then look what happened. At the time in 2002, 40% of US women who were menopausal were using hormone therapy. 40%. Now it's 6 to 7%. And within those years, there was a 79% decline in hormone therapy use. That's that orange line going down. But look what happened to the breast cancer incidence. It went up by 0.5% every year, and it continues to do so. Now, I'm not saying it's going up because we're not using hormones. Maybe, I don't know. But it's certainly, if everyone drastically went off of it and it continued to go up, why did the breast cancer incidence keep on, So, yeah. So you now know why doctors are scared and afraid, right? And it's also because doctors are really busy, and we go by like we hear a headline and a buzzword that a medical society might say, right? But we're not really good at effectively explaining risks and benefits. This is very important for you guys. I'm taking you all to the theater right now. So this is a PhD, Eric Rifkin, and he published this amazing paper in the Cancer Journal, June 2022. It's called Effective Image Communication of Risks and Benefits of HRT. So let's look at what the risks actually are. So on one side, you see this is a theater of 1,000 women. And you see those two black seats there, right? So those are two women. That's your baseline risk for the average menopausal woman. That's your baseline risk of venous thrombophlebitis. So a DVT leading to perhaps a PE, right? That's your risk. On the other side, there's 2 extra cases for every 1,000 women. The WHI data, they reported this as a 2-fold increase or 100% increase. That sounds scary, but it was actually 2 extra people but what's even more important, this was using oral, synthetic, progestin, and estrogen. It's not that those are wrong formulations. They're not for some women. I don't want you to be scared of them. But let's take it into context. It doesn't even apply to the formulations we're using today, right? So the other thing is they often throw in stroke with DVTs, right? So I want you to understand it's like all one, but they're very different things. And actually the WHI's own data showed that stroke is statistically non-significant and rare. And all of the majority of data says that. So take the stroke fear out of your minds as well. And then here's the mother load, right? This is the reason why you've been denied hormone therapy is this, okay? Women's Health Initiative, 2 arms of the study, 1 estrogen alone, because you didn't have a uterus, 1 estrogen and progestin. In the estrogen and progestin arm, the annual increase of a diagnosis of breast cancer went from a baseline of 3 per 1,000 to 3.8 per 1,000, represented on here as 1 additional seat in the theater of a diagnosed breast cancer, but never a breast cancer mortality. At the 20-year follow-up, it's the WHI's own data still reported that there was no increase in breast cancer mortality, just an incidence, and even this 1 extra seat for every 1,000 women if you can believe the WHO's data, that's a very small amount. But even this part of the data has now come into question. There's a beautiful review article called "'Tis But a Scratch" by the author of Estrogen Matters, Dr. Avram Blooming, where he just elegantly lays out all of the statistical and reporting problems of why even this is a problem, right? But this extra one additional case of diagnosed breast cancer for every 1,000 women is similar to what we tell women is your risk if you have too much wine or you're having an unhealthy lifestyle. So let's just, even if we believe this, let's take this into context. And then this is pretty, now look at all these seats filled in the theater, ladies. This is 900 out of it. Ooh, sorry. Here, this is the, oops, one more. Oh, hold on, I'm sorry. So listen, this is 900. All right. So I'm sorry, that was the one additional case. I'm sorry, I hadn't done that. So this is 900 out of the 1,000 women in the WHI, this is their numbers, who benefited from symptom relief. But when they released their data, they wrote that HRT did not have a clinically meaningful effect on quality of life. That was their report. And you know why? Because in the study, they excluded anybody who had hot flashes because they didn't want them to know who was on placebo and who was getting the hormones. So so their data could go out saying it didn't help their quality of life because none of the women in it had hot flashes. But this is actually what the data showed. If you looked at the subset of women who did report it, 900 out of 1,000. So that's a full theater. That's what we should be talking about, right? All right, I'm going to skip this next slide because it gets a little in the weeds, and we're going to go right to the ideal candidate for hormone therapy. So even if you can find a doctor who wants to help you with your menopause symptoms, they only want to treat the ideal candidate. And that's the stereotypical menopausal Barbie, which doesn't really describe any of us, right? This is a woman who is, maybe 52, last period is a year ago. She's what my ideal body weight in my mind used to be. She's 5'7" and 128 pounds. That's not what my weight is now. It's okay, it doesn't matter. She has moderate to severe vasomotor symptoms. She's got no other history, no family history. Her breast density is 0, and she's got a beautiful lipid profile. This is unrealistic. It's nonsense because we are all weird Barbies. This is prescribing hormone therapy in the real world, people, okay? We are weighing the risks and benefits, our Birks and our heels. Like, we have to make choices, and we're complicated and we're messy. We're scarred up by our husbands and our kids and society and our jobs and the WHI, right? It's true. Yeah, I will. All right, so we're going to tackle all these different things. All right, so a family history of anything, I don't care what it is, does not preclude the use of hormone therapy. In fact, it might raise some flags of a reason why I want to give it to you. Oh, mom had a hip fracture at, 67, or you've got a strong family history of cardiovascular disease. I don't want to wait and deny you care. I want to prevent it, right? And one of the most common reasons, family history, is breast cancer, which we will talk about. But a family history of breast cancer is not a contraindication to hormone therapy. Chronic medical conditions. Up to 80% of women in menopause will have some chronic medical condition of some sort. This is just the most common ones. Hypertension, high cholesterol, diabetes, migraines with aura. None of these are contraindications. In fact, many of them are indications. Hypertension, whether it's oral or transdermal estrogen, is not a contraindication, has not been shown to have an impact on blood pressure. Oral birth control pills could slightly elevate your blood pressure, but oral estrogen in menopausal hormone therapy is much lower dose. We don't see a negative impact. There really isn't an impact on lipid markers in a negative way, and frankly, they may be beneficial on your lipid metabolism, and that's a whole nother discussion, but it can be very helpful. Diabetes, 30% decreased risk of developing type 2 diabetes in women who are using estrogen therapy. Migraines with and without aura, absolutely not a contraindication. we just often recommend starting lower, titrating up to your symptoms so that the estrogen doesn't like maybe trigger a new migraine, and use a transdermal approach. So, you know, lots of myths there. Blood clotting, big, super, super, super common myth that you have some family history of you carry a mutation like factor V Leiden or protein C, MTHFR. In pregnancy, many women might have been tested for mutations because of some pregnancy complications. So they come to menopause being like, oh, I can't take estrogen, you know? Meanwhile, you've had estrogen in your body for the last, you know, all these years. Suddenly it's dangerous for you. We have actual data on this. This could be a whole presentation in itself, but here's my receipts. The Circulation Journal, Menopause Consult, NAMS Practice Pearl. Bottom line is anybody who has a predisposition to blood clots for whatever reason, your risk is your risk. It's elevated from the general population. If we give you transdermal estrogen, we would avoid typically oral estrogen. It doesn't further increase your risk. Just it's really that simple. None of these things are contraindications. So if your doctor's telling you that, print up these journals and be like, you're wrong, you know? The other thing is GYN history. There's lots of women with endometriosis out there who had their ovaries removed early or their uterus removed early, and they're denied access to estrogen because it says, oh, it's going to cause your endometriosis to come back. There is data on this. It does not cause it to come back, but many prescribers of hormone therapy don't read the data, and they don't realize these women should probably also be given progesterone along with their estrogen, because with endometriosis, theoretically, you're leaving behind some cells, some endometrial cells, because that's what endometriosis is. So giving them unopposed estrogen is not as good of an idea. And I've had patients who they've started HRT without progesterone because they don't have a uterus, and suddenly they have, you know, pelvic pain. It happens. So they can still have HRT, just give them some progesterone. HRT is not going to make your fibroids regrow. It's not going to make your adenomyosis regrow. Ovarian cysts are not a contraindication. And yes, we have data on uterine and ovarian cancer survivors. Again, it depends on the stage, the type, but in general, they can also have hormone therapy. The next is premature menopause, all right? The most to lose, the most to gain. These people are terribly neglected, right? The negative perceptions of hormone therapy that the WHI caused made doctors even fear giving women who were, I swear, 28, 32, 34, who had, let's put the breast cancer stuff aside, you know, ovaries removed for benign reasons or for preventative reasons, like they carry the POLB2 mutation or POLB mutation or a BRCA mutation. They're not getting estrogen, and the Mayo Clinic cohort study showed these people who have premature menopause for any reason have a 67% increase in all-cause mortality, an 85% higher risk of stroke, a 98% increased risk of cardiovascular disease. The guideline, this is not controversial stuff. The guidelines are very clear. These women should have hormone therapy up to at least the age of natural menopause, and then they can choose to continue. It's really not happening. And then the fear of breast cancer is the primary driver behind most menopause health decisions by women and their doctors. So you're going to hear it over and over again this week. But remember, in the estrogen-only arm of the study, there was a lower breast cancer mortality incidence, 30% decrease, right? The preponderance of data, and this is directly from the Menopause Society 2022 guidelines, say that there is no additive effect of estrogen, appropriate FDA-approved estrogen, on your breast cancer risk, okay? And you are more than just your breast. It's not the only thing you should be worried about, right? And yeah, so there's that statement, right? This is the preponderance of data. It's the elephant in the room. It's what's getting in the way of the conversation. So if you're going to go to your doctor who's, you know, you want to talk about hormone therapy and you think that they're going to like push back on you, you need to be well informed of what the guidelines actually say. And it's pretty easy because you could print out the 2022 guidelines and highlight this statement. This is directly from it. And be like, I don't think you're actually giving me good advice. Can we please discuss this? Okay. And, you know, formulation does matter, perhaps. and Heather Hirsch at the Menopause Society maybe 2 years ago, they said, what are the top 10 things to know? And Heather presented on a paper that basically looked at formulation, and it said estrogen alone, no increased risk of breast cancer. Estrogen with a synthetic progestin, well, maybe we'll quote, they quoted those numbers from the WHI, which are still probably not statistically significant, but we'll give them that. But the big news on what she was talking about was that the study showed estrogen with oral micronized progesterone had no increased risk. So we just need to move on from it and stop talking about it because we have to keep on talking about it, but you know what I mean. So, and then we'll take it one. So whenever a provider pushes back on the breast cancer thing, I go, listen, in 2016, quite a bit of time ago, the Menopause Society has a very explicit practice protocol that said the preponderance of evidence tells us that even in the most high risk women, BRCA1 and 2 carriers, up to 80% risk of getting breast cancer, it says they should not defer and wait on having their ovaries removed to protect them from ovarian cancer, right? Because we don't have a good screening test for that, out of fear that they can't take HRT. And many of them think, well, I have to at least have a mastectomy first before I can have HRT. But no, the guidelines and all the data say, no, it's not going to further increase your risk. Get your ovaries out. You can take your HRT, and then you can choose if you'd like to have a prophylactic mastectomy. But doesn't preclude you from having hormone therapy. And so that was 2016. And then this year in the Cancer's Journal, this beautiful article on the long-term non-cancer risks in people with BRCA mutations following a risk-reducing removal of both of their ovaries and the role of hormone therapy. And it really doubles down. And they did another rehash of all of the science and says, yeah, we're really just, doing a disservice to women. And it quotes that the WHI fears continue to affect how we treat these women. And again, I'll meet with any breast cancer survivors. We'll do our own little mini lecture. But, the conversation, it's going forward. This train's not stopping. And I'm not saying this is the right answer for everybody, but we do have data on breast cancer, hormone therapy after breast cancer. All right. Again, this is a whole separate lecture, but I just want you to know that there is data. It's small data. It's not perfect data, but there's data. And we have a right to have access to what information is there so that we can make decisions for ourselves. It may not be an option for everybody, but it's an option that you can talk about with your clinician. And then my friend, Kelly Casperson, one of her podcasts, she's like, it was titled, Boomers Should Be Pissed, because they should be. Now, who knows what that is a picture of? Well, I know you know. Let me say, I know you know. What is it, Lisa? It's a clitoris, and that clitoris is pissed. That's what your clitoris looks like, actually. Only normally the arms are down, right? So this is, listen, the 10-year window, okay? We get it. I got it last night. We know from all the data that your benefits, your biohack, as Dr. Von der Reit said, is going to be most effective if you introduce estrogen within the first 10 years. Really, honestly, the sooner rather than later. But it doesn't mean that you suddenly, like you're not Cinderella at on the dot at 10 years. Oh my God, you turn into a pumpkin. You cannot have this. Of course not. Of course not. There's the spectrum, right? And so if you're at that 10-year mark or longer at 15 years, and honestly, 20 years, and you feel like you either have persistent symptoms, because 10 to 15% of women will have vasomotor symptoms for, the rest of their lives. And others will just say, well, I don't have hot flushes anymore, but you know what? My joints are creaky. I'm osteopenic. I don't sleep well. My sexual life isn't. I want to try this. I want to have a chance. I want to try it. So we weigh their risks and benefits. We see, do you have any true contraindications, like big ones, active liver disease, unexplained vaginal bleeding? You're in the middle of active breast cancer treatment. Some obvious big things. You just had a quadruple bypass. Outside of that, I'm like, okay, let's start low, a transdermal, which is very safe in terms of blood clotting risk. It's a reasonable option to say that, oh, you can't do it. It's actually not even what the data says. The data says that it's probably just neutral on your cardiac health, after 10 years. You're not going to get all the big benefits, but you're also not going to drop dead of it. It's ridiculous to make it so black and white, right? And so, so we get to this point, and this is really kind of where I hope this gets you revved up. So you guys can all go back to your regular life after this cruise, or you can know the truth about the universe. You can really spread that word and make decisions for yourself, okay? I really believe that menopausal hormone therapy is an extension of reproductive choice. We fight for access to contraceptive counseling, STD testing, abortion care, her body, her choice. Why is it that when we get to menopause, we don't have a choice anymore? Okay, we take evidence based, not fear based. We do risks versus benefits, shared decision making, informed consent, and patient autonomy. These are ethical principles that should apply to every aspect of medicine, including midlife women's health. And so to end it here, this was a message I got on February 2nd at 12:41 a.m. from a patient on Alloy. This is the day that the New York Times article came out, and I prescribed for her. And she says, Dr. Menn, thanks for responding so quickly. I would rather go with the estradiol pill. I'm so excited about this. I've been in hell for 2 years, and I thought hormone therapy was not safe. The New York Times article today changed everything. I'm so grateful to that reporter and to you all for being there. Thank you. And I was so excited. I was like, ooh, I'm getting her hormone therapy. It's so amazing. And so I want you to be able to go off to see your gynecologist or your internist, or if they're not helping you, come to one of the telehealth companies, come to Alloy. Speak up, demand access, because you deserve to get the care that you're owed. And yeah, and you'll obviously see me for the next bunch of days. You can find me on social media. You can, message me. You can go to Alloy. And thank you for being my audience. I don't know. Do I not have time for questions? Yeah. Any questions? Any questions?
Wait, hold on, we gotta talk in here.
Yeah.
Okay, ready?
I'm just wondering if Alloy, if you would also treat people outside of the U.S.
No. You have to be licensed in the state that you provide care in.
Okay.
So not yet. Not yet. Oh, the Canadians are really suffering.
You ready?
No, they are. I get messages all the time. It's bad up there. Oof.
This one? Okay. Okay. Also, football fans, go Detroit Lions. Sorry. Very controversial, but all right, Lions. Okay. Okay, no, you're 51, I'm 50. Okay, my mom died of breast cancer over a decade ago. I had kids in my 40s, so I had a baby at 43, a baby at 45. I live in Mississippi. I'm not even going to tell the stories of the doctors that I've seen there.
It's bad.
So bad.
I know.
The things that they have said. So anyway, I got an IUD out because they told me I can't have it because of breast cancer. It stopped my horrible periods for 2 years, and I was like loving life.
It's not a contraindication.
Yeah. So anyway, I got it out, all of the things, whatever. So I'm just, and my father's mother died of ovarian cancer. So what I'm hearing is I should ask to get the tests again, even though I've had the BRCA test.
So you should make sure your testing is up to date because testing evolves. Panel testing evolves. And you may or may not need testing. But remember, you can have your cake and eat it too. You can know your risks and manage it with preventative health choices, whether it's surgeries or preventive medications, increased surveillance.
Okay.
And you can also have access to options for managing your menopausal symptoms, hormone therapy being one of the options in your toolbox, for sure.
Okay. Thank you.
There's no reason why, just a family history again is not a reason to deny access to hormone therapy. Any other questions?
Have there been any studies sort of analyzing the risks between HRT and other types of cancer, like skin cancer or anything like that?
Meaning, does HRT cause any cancers?
Or could it help?
Yes, there's actually a lot of data actually out of the WHI showing a significant, we don't talk about this enough. I didn't talk about this. Colon cancer, significant decrease in colon cancer risk, perhaps lung cancer, estrogen only arm. Let's just make this clear. The estrogen only arm showed a 30% decreased risk of breast cancer. Just hold on to that for a second. But yes, there is. But the colon cancer is probably one of the biggest cancer associations that's improved. But there's not enough data.
Hi. So it's not really a question, it's just appreciation.
Oh, thank you.
I appreciate you including those of us that have premature ovarian insufficiency in your talk because we don't have any platform, any access. The NIH is the best we can find. And
It's terrible, the NIH information. It's so bad because they quote the old WHI stuff, right? So it scares our premature menopause women. The data, anything you hear about hormone therapy, it doesn't apply to you. You guys are hormone replacement, full higher dose replacement. It's not menopausal hormone therapy.
But there's nowhere to go. So coming here is at least somebody talking about menopause.
Well, thank you for the feedback. But it's really important for you to know that it's really not controversial. The premature and ACOG, all the medical societies, it's actually medical malpractice to not give full estrogen up to at least the age of natural menopause unless there's a true contraindication, which that's medical malpractice. But I see it constantly. It's atrocious. It's bad.
Just
Yep.
real quick, you mentioned something I hadn't even thought about, fatty liver disease. Can you?
It's not a contraindication.
Oh, thank you.
You know, there's different types of liver disease, of course.
Right.
Like but in general, non-alcoholic fatty liver disease is a metabolic syndrome, frankly. Dr. Mary Claire, all her discussions and Von der all these people are talking about all the metabolic changes that are happening. And one of them is that there's fat accumulation in the liver.
Right.
You can be monitored and checked and work metabolically, but you can have transdermal estrogen. I mean, you see this question all the time, probably.
I need that.
It actually is probably part of the solution. It's not a contraindication.
There's pretty good data showing that we can track FSH levels and liver health with hormone replacement therapy. I think that's the next big thing.
100%.
We can't estradiol is really symptomatic, but for certain metabolic things, using FSH as a marker will be a way that we can look at decreasing the risk of chronic disease. Getting that FSH down here.
In fact, I think non-alcoholic fatty liver is almost my green flag of I'm like, she's someone who actually needs it, not to be withheld, which is counterintuitive to the many people think, but it's not based on reality the way they're advising you.